Our article is on the persistence of primitive reflexes and associated motor problems in healthy preschool children. Primitive reflexes are reflex patterns that appear during gestation or at birth and usually integrate by 4 to 6 months of age. Integration indicates maturation of the central nervous system. The persistence of a primitive reflex means that the reflex has not integrated at the proper time, which can cause problems with development. There are many studies on primitive reflexes for children with cerebral palsy, but there are not many for healthy children. The purpose of this study was to determine the occurrence of persistent primitive reflexes in healthy 4 to 6-year-old children and how it impacts their psychomotor development. Here are some abbreviations that are commonly used throughout the study.
This study was an observational study looking at how reflexes can impact motor development. The participants of the study included 35 healthy children between 4 to 6 years old in a school in Poland. Children with any special education needs were not included in this study. Each child's age, height, sex, and BMI were taken, as well as the perinatal measurements such as the APGAR score, their birth weight, the week of birth, and the type of birth, such as a natural childbirth or a C-section. The outcome measures taken during this study were asymmetrical tonic neck reflex, symmetrical tonic neck reflex, tonic labyrinthine reflex, and the motor proficiency test. ATNR was carried out in a quadruped position of the child with shoulders and hips flexed to 90, elbows extended, hands flat, fingers extended, and head in a neutral position. The examiner gently rotated the head passively to the right, laterally, and held for 5 seconds. The head was slowly rotated back to the midline, and then the procedure was repeated to the other side. This sequence was repeated 4 times. The left and right sides were tested using a 5-point rating scale. The STNR was carried out in a quadruped position as well, with the head passively bent and extended. Flexion and extension were both tested using a 5-point rating scale. The TLR was tested in a standing position, feet pushed together, hands along the trunk. The child was asked to tilt the head back as if looking at the ceiling and close the eyes. The child was supported by the examiner. After 10 seconds, the child was asked to bend the head slowly as if looking at the toes, and stand in that position for 10 seconds. The movement was repeated 4 times, and a rating was measured using a 5-point scale. Motor proficiency tests included 18 tasks, which were divided into 4 areas, including stability, locomotion, object control, and fine motor skills. It was measured on a 3-point scale. The higher the children scored in the primitive reflex test, the lower the integration they represented. The higher the movement skill level, the higher the children scored in the MOT 4 to 6 assessment protocol. Once the measurements were performed and scored, the statistical analysis was carried out using Statistica version 10. The results were expressed as means plus or minus standard deviations. The differences between girls and boys and their body parameters were tested by students' t-test. The statistical evaluation was performed using the Pearson's correlation, and all parameters were considered significantly different if p was less than 0.05.
Of the 35 healthy children studied, 11% did not retain any primitive reflexes. The remaining 89% did. Of those that did, 65% of them presented with reflexes to a minimal or mild degree, which corresponded to a 1 or 2 on the 5-point rating scale. 35% presented with reflexes to a higher degree, corresponding to a grade of 3 or 4. The reflex most frequently demonstrated was ATNR left, which was present in 66%. The least frequent was STNR flexion, which was present in 34% of children. The children's psychomotor abilities were also measured using the motor proficiency test, which was a series of 18 tasks. The skill mastered the most by 94% of children was rolling around the long axis of the body. The skill mastered the least by 6% was catching a stick. The skill of reverse balance was attempted to some degree, but was not mastered by any child. The study also compared development between girls and boys when looking at the motor proficiency test and the level of retained primitive reflexes. The motor proficiency test indicated that no one had accelerated development. Only 5% of girls had very good development. 58% of girls and 60% of boys had normal development. 32% of girls and 27% of boys had delayed development, and 5% of girls and 13% of boys had altered development. Of the retained primitive reflexes, 11% of girls and 13% of boys did not retain any reflexes. Low-level reflexes were present in 58% of girls and 53% of boys. Medium-level reflexes were present in 26% of girls and 27% of boys. High-level reflexes were present in 5% of girls and 13% of boys. And no children retained max-level reflexes.
Discussion and conclusion. Most of the children in this study demonstrated persistent reflexes, proving that healthy children can have retained primitive reflexes even if they do not show drastic signs of it. This study showed that any degree of persistence affects the psychomotor development of the child. We learned that motor efficiency has an inverse relationship with the severity of the reflex. Essentially, the more prominent the retained reflex, the more clumsy a child will be when performing various psychomotor activities. Because of this, it is important to find the underlying cause of the psychomotor problem, rather than just treating the dysfunctions that are seen externally. Early detection and treatment of persistent reflexes is key. This study demonstrates that failure of implementing a primitive reflex integration program could prevent the child from ever obtaining normal motor skills for their age. Without addressing the persistent reflexes, it may be impossible to correct the motor disorders and clumsiness in children, inhibiting normal development.
As physical therapists, we can clinically apply this research in our practice in a myriad of ways. It would allow us to advocate for large-scale screening and testing to be considered early on in childhood before the aberrant behaviors are noticed in school-age children. This would help in implementing the therapy of these children as early as possible and reducing the developmental complications experienced later in life. We can also use the screening techniques therapeutically to help these children with persistent reflexes by repeating the movement pattern from the first year of life. What are some examples of us doing so? Creating annual screening beginning at age 1 to 2, and integrating developmental therapy in with child care. Most primitive reflexes should be integrated by about 1 to 2 years old, so this would be a good age to start. We can provide screening to these kids at this age, and if significant persistent reflexes arise, we can enroll them into therapy to reduce the developmental effects later on in childhood. We would provide this annually until the reflex is integrated. We can also provide day-to-day child care services that implemented developmental therapy into a curriculum to meet certain goals or developmental milestones.